There is evidence to suggest that long-standing systemic inequalities and structural racism play a role in driving race disparities in obesity. A study of 324,572 U.S. adults reported that structural racism, assessed at a county level using a model that included domains for residential segregation, employment, education, healthcare, and criminal justice, was associated with higher BMI in African American people. A prospective study of 4,315 incident cases of obesity in African American women also found that both everyday racism and lifetime racism were positively associated with increased incidence of obesity. In addition, a longitudinal prospective cohort study reported an association between higher perceived discrimination and a positive BMI trajectory in African American adults. One conduit through which structural racism makes a major contribution to racial inequities in health between African American people and white people is by driving social circumstance. For example, residential segregation remains common, concentrating African American people in neighborhoods that lack access to adequate education and health care, have increased exposure to air pollutants, and have increased rates of crime. Residential segregation is also associated with an increased risk of obesity, specifically among African American women. Furthermore, access to health care is based on ability to pay rather than on patient needs, causing harm to racial and ethnic minorities who are disproportionately poor and lack access to health insurance. HCPs should therefore consider the social determinants of health, such as housing, employment, and healthcare access, that may influence their patients' behaviors and opportunities for health in order to provide the most appropriate care. The impact of racism on health outcomes is rooted in a history of unethical experimentation on African American people for medical research and training and segregation of care based on race. One of the most infamous medical experiments was the Tuskegee study, led by the U.S. government from 1932, which investigated the natural history of syphilis in 600 African American men. The participants were misled as to the purpose of the study and were denied effective treatment long after penicillin was recognized as the drug of choice for syphilis. The study was ultimately deemed ethically unjustified and was discontinued in 1972. Another example of federally endorsed inequity in healthcare is the passage of the Hill-Burton Act in 1946, which created separate but equal healthcare facilities financed by the U.S. government throughout the country. These facilities were anything but equal, with those for African American people often lacking the resources and equipment of those for white people. This sanctioned segregation of healthcare resources, combined with a distrust of medical professionals given the experiences of the Tuskegee study and decades of non-consented experimentation and medical exploitation, has had long-lasting effects, with African American people less likely than white people to participate in research and trust the healthcare system and medical researchers. Interpersonal racism. Individual or interpersonal racism is defined as directly perceived discriminatory interactions between individuals, whether in their institutional roles or as public and private individuals. Interpersonal racism can be conscious or unconscious, and can manifest in healthcare via unconscious bias of HCPs. Interpersonal racism between individuals may affect the disparities in obesity rates, as major discrimination, e.g., being unfairly treated, abused by police, overt racial discrimination, e.g., use of racial slurs, and microaggressions, subtle messaging that conveys hostility or exclusion, are associated with obesity among African American people. The association between racism and obesity appears to be in part mediated by stress and through negative behavioral responses such as decreased exercise and increased emotional eating. Increasing the potential for bias among African American people with obesity is the interaction between racism and the stigma of obesity. African American people with obesity are at the intersection of these two types of discrimination and may therefore experience an even greater amount of bias. Therefore, structural and interpersonal racism impacts health outcomes. However, this is not routinely taught to medical students or covered widely in medical literature. Although the physical links between discrimination and health are understood, This has not translated into educating HCPs about the impact of racism on health. To reduce the health disparities in African American people with obesity, HCPs must understand how structural and interpersonal racism contribute to these disparities and take an active role in addressing the root causes. Patient HCP communication. Unconscious or implicit bias is a form of interpersonal racism. Scientific data have demonstrated that HCPs have implicit bias against African American people and people with obesity, and this can affect clinical decision-making. Although some communication challenges around behaviors and behavior modification are not specific to African American people, suboptimal communication and a lack of shared decision-making may exist between non-African American HCPs and African American people. This may lead to poor patient engagement, an important issue in obesity management. According to patients' reports of their HCP's behavior, African American people, particularly those with obesity, were less likely to report that their providers explained things well or spent enough time with them. Compared with white people, African American people with BMI class 30.0 kilograms per meter were also less likely to receive an obesity diagnosis compared with white people. People with obesity with a provider of the same race ethnicity were more likely to report receiving diet advice from their provider than those with differing race ethnicity. The way in which HCPs communicate about obesity and its management influences how patients relate to the messages, potentially affecting weight management success. Access to healthy foods and exercise. Environmental challenges, such as poor quality diet, availability of healthy foods, and inactivity, are universal, but there is some evidence that they may be more challenging for African American people. Studies have shown that African American people have a less healthy diet than other racial groups, with a higher consumption of foods and beverages with added sugar and fried food. Several barriers have been identified that limit healthy eating, including lack of knowledge, cost of healthy food, lack of time to prepare healthy meals, need for transportation to access stores and markets, and miscommunication with doctors about healthy eating. African American people aged 45 to 64 years are also less likely to engage in physical activity than other racial groups. Barriers to physical activity among African American women with obesity include lack of awareness of how, where, and how much to exercise, cost of exercise programs, lack of accessible facilities, lack of transportation, and health concerns. However, several factors are associated with increased exercise or motivation for exercise among African American people, including family interaction and connection to the community. Neighborhood factors also contribute to challenges in accessing healthy food and exercise in African American people. Neighborhoods with higher proportions of African American people have higher densities of fast food restaurants and advertisements related to unhealthy food and beverages, and fewer safe spaces for activity than predominantly white neighborhoods. Neighborhood factors have been shown to impact obesity prevalence. With lower odds of obesity among African American women living in a neighborhood with a supermarket, and among African American men living in a neighborhood with a park. Health insurance and access to medication. Health insurance coverage is often a challenge for people with obesity. Among a sample of urban residents, the prevalence of obesity had grown rapidly over 10 years among uninsured people across racial groups. Safety net health systems, in delivering care to under or uninsured, publicly insured, and other vulnerable populations in the United States, generally support a relatively high proportion of African American people. However, few health insurance plans include coverage for comprehensive obesity care, including access to obesity pharmacotherapy. Medicare excludes drug therapy for obesity, while Medicaid drug coverage varies by state. In addition, older medications for obesity-related complications, particularly type 2 diabetes, tend to be more obesogenic than newer alternatives and are often cheaper and therefore likely to have better reimbursement. Body image perceptions. There are also different perspectives on cultural norms for body image and perceptions of beauty and obesity among African American people. African American people have a more accepting view of larger body sizes than white people. Being curvier is often seen as desirable, with many women striving for a fuller figure. Many African American women have misconceptions of normal weight, describing their weight as healthy despite being overweight by BMI and underestimating or underreporting their weight category. However, due to this acceptance of larger body sizes, it may be easier to set realistic treatment goals, as African American people may not desire the ideal of achieving a normal BMI, which is rarely achieved with treatment. Strategies for managing obesity in African American people. A holistic approach incorporating multiple strategies is needed to support the management of obesity in African American people. Addressing health disparities and racial bias. Reducing health disparities among African American people is key to improving health outcomes. The U.S. Office of Minority Health's strategic framework for improving racial ethnic minority health and eliminating racial ethnic health disparities includes effective solutions to reduce health disparities. These include strategies to address factors on an individual, e.g., improving knowledge and behaviors, environmental, e.g., promoting a healthy physical and social environment, or systems level, e.g., improving science and knowledge and promoting workforce diversity. A review examining whether obesity is a manifestation of systemic racism proposed a 10-point strategy for study and intervention, which highlighted the importance of conducting intersectional research on obesity and racism to evaluate whether obesity is another aspect of structural racism that impacts African American people. Addressing implicit racial bias could also reduce health disparities between African American and non-African American people. In a prospective observational study, including implicit racial bias training as part of the formal curriculum at medical school, reduced students' racial bias over 4 years. Informal training also has the potential to reduce racial bias. One such initiative is the 21-day Racial Equity Habit Building Challenge, which supports HCPs to further their understanding of racial inequities, including addressing unconscious bias. Increasing the diversity of the HCP workforce is also key to addressing racial inequities in healthcare. Efforts are ongoing among professional medical societies, the American Medical Association, medical schools, the Association of American Medical Colleges, and colleges and universities, historically black colleges and universities, to increase HCP and researcher diversity. Diagnosis and communication. Ensuring African American people receive a diagnosis of obesity is also key to weight management, particularly given the perceptions related to acceptance of a larger body size in this population. 44759. People with overweight or obesity who are told by HCPs that they have overweight are more likely to perceive themselves as having overweight, be interested in losing weight, and have recently attempted to lose weight than those whose HCPs have not acknowledged they have overweight challenge. For many, having this discussion with a provider might be the first time they get a full sense of the impact of excess weight. When communicating with patients, a diagnosis of obesity should be linked to disease risk, as smaller body size may not be such a motivating factor for African American people as in other racial groups. Among African American people with obesity, health is considered the most important reason to lose weight. However, as many African American people do not recognize the health implications of obesity, this must be emphasized when communicating with patients. Focusing on the potential benefits may be an effective motivator for weight loss for African American people. HCPs should also set specific weight goals with patients, as many are unaware of the degree of weight loss required, e.g., sustained weight loss of 5% to 10% to significantly improve health. Culturally relevant intervention strategies. Health interventions to reduce obesity among African American people should be personalized and culturally specific, with aims that include engaging with and, when necessary, challenging cultural norms. A systematic review of culturally adapted weight loss strategies for African American people identified a number of features common to studies with successful outcomes. These included addressing traditional foods, food insecurity, and spirituality and faith, as well as conducting focus groups and using peer educators. In one successful weight loss program for African American people, cultural adaptations included decreasing the cost of the program, using culturally appropriate recipes, addressing attitudes about exercise, and including family and weight loss efforts. This program was associated with significant weight loss and improvements in risk factors for obesity-related complications. Physical activity should also be encouraged as part of weight management for African American people with obesity. However, this too should be culturally sensitive. The type of exercise suggested is important, as for example, swimming may not generally be part of African American people's leisure, exercise, and sports culture because of past discrimination restricting access to swimming pools. Community and faith-based initiatives can be successful in managing obesity among African American people. Faith-based weight loss interventions in African American people have been shown to successfully reduce weight, improve diet, and increase physical activity among participants. The inclusion of family and social ties has also been a feature of successful weight loss interventions in African American people. However, friends and family may not always be supportive of weight loss, with some African American women reporting relationships becoming more competitive and less supportive, and a loss of identity and companionship that accompanied weight loss. Pharmacological and surgical intervention. Pharmacotherapy, particularly when used alongside lifestyle interventions, can be effective for people with obesity. U.S. Food and Drug Administration approved therapies include liraglutide, orlistat, phentermine, phentermine topiramate, bupropion naltrexone, and most recently, semaglutide. In a Phase 3 study in which 19% of participants were African American, phentermine topiramate demonstrated significant efficacy in inducing weight loss, 75. Although data comparing weight loss between racial and ethnic groups are limited, racial differences were not seen to influence the safety or efficacy of semaglutide, liraglutide, or orlistat in studies on obesity that included African American people, 76, 77, 79. Several barriers to anti-obesity pharmacotherapy and bariatric surgery utilization exist among African American people. For pharmacotherapy, these include fear of side effects, 89, whereas for bariatric surgery, these include the fear of complications, high cost of surgery, and the perception that it is too extreme and should be a last resort, 89. African American women are also apprehensive about the lack of control over how much weight could be lost with bariatric surgery because of the preference for larger body sizes in this population. Lack of awareness of pharmacotherapy and bariatric surgery is another barrier, as few HCPs have discussions with their patients about these options. It is therefore critical that HCPs communicate the potential benefits of pharmacotherapy and bariatric surgery options with their patients and address concerns. Summary: long-standing disparities in health and obesity care for African American people have been documented, and systemic racism remains a major cause. Systemic racism limits access to healthy foods, safe spaces for exercise, health insurance, and treatment, while HCP's unconscious racial bias can negatively impact interactions with patients. Reducing health disparities is key to improving health outcomes. Figure 3. Racial bias can be reduced by racial bias training programs to support HCPs, furthering their understanding of racial inequities and unconscious bias. Efforts should also be made to increase the diversity of the HCP workforce. HCPs are encouraged to develop appropriate culturally sensitive practices when engaging with African American people with obesity. Furthermore, any weight loss interventions should be personalized and culturally relevant to African American people. Weight loss programs can include use of peer educators and community and faith-based programs. The response to lifestyle interventions can be augmented with greater use of anti-obesity pharmacotherapy and bariatric surgery. These strategies are underutilized in general, and even more so in African American people. It is therefore important that HCPs ensure awareness of pharmacotherapy and bariatric surgery options and their potential benefits among African American people. Thanks for listening. Until next time, be good.